In this video lecture, we are going to learn about symptom checklists. Symptom checklists are quite useful not only during the first session to screen for certain problems such as depression or anxiety, but also to track progress over time. If the client has a diagnosis of, say, depression, we want to know how they're doing months later during treatment. And also if any clinical issues arise during treatment, such as, for example, we're interested in whether or not the client has clinical level issues of anxiety later on, that can also be useful then. Symptom checklists kind of arose in this historical context of an increased need for diagnostic procedures with the advent of the first edition of the Diagnostic and Statistical Manual, the DSM, which was first published in 1952. In the DSM, a diagnosis is defined as a cluster of symptoms. So, for example, if you have 5 of 9 symptoms, then you meet the criterion for that diagnosis. And because diagnosis is basically a certain number of identified symptoms, checklists were created to identify whether or not people had enough symptoms to meet the criteria for the disorder. Insurance companies often require diagnoses in the first session, and to diagnose, we not only use clinical interviews, but often symptom checklists to give us more rigorous quantitative information for whether or not the client actually meets criteria for the disorder. Here are the symptom checklists that we're going to explore as part of this video lecture. The Beck inventories, the Beck Depression and Anxiety Inventory, and we're also going to talk about some other checklists that measure depression and anxiety, substance use, eating disorders, ADHD, self-injury, and anger. Towards the end of this video lecture, we're also going to learn about the DSM-5 Level 1 and 2 measures, which are available free online, and I have those and will be giving them to you as part of this course. The Beck inventories were referred to as the skinny by a psychiatrist at the Child and Adolescent Psychiatric Unit where I used to work. Skinny in that they only measure a certain number of things. For example, the Beck Depression Inventory just looks at depression, whereas comprehensive psychological assessments such as the MMPI tend to measure a wide variety of psychological issues. Used alone, they can be useful to track certain symptom patterns, but they aren't comprehensive in scope. The Beck inventories are probably one of the more famous and well-known symptom checklists that exist currently. The objective of the Beck inventories, for example the Beck Depression Inventory, is to measure depressive symptomology against a criterion. This criterion was developed by Beck and his colleagues, who met together and decided what the symptoms of depression were and to what level of severity was needed to meet the criterion for mild, moderate, or severe depression. The goal here was to diagnose depression and to track progress over time. These are standardized criterion-referenced instruments. Standardized in that the same questions are asked in the same order to every test taker. Criterion referenced in that, again, Beck and his colleagues established these cut scores for what was mild, moderate, and severe depression or anxiety. They have excellent utility because they can be taken in 10 minutes, which is good for clients. They use an ordinal scale from 0 to 3, not at all to often. Again, this has problems when you start getting into more rigorous statistical analysis, though is quite useful for clinical work because it's easy to score. And they're scored by adding the number or the sum of items. So, for example, if a client rates themselves 2s throughout the assessment, you would add up the 2s for each of the items. That gives you a total score, and that total score is compared with these cutoffs for whether or not the client has mild, moderate, or severe depression. Here are the guidelines, the cutoffs, for Beck Depression Inventory Interpretation. This is based on the 2nd edition. A score of 0 to 13 is normal ups and downs. 14 through 19 is mild mood disturbance. 20 through 28 is moderate depression. And 29 to 63 is severe depression. Aaron Beck's work on depression, and this includes the Beck Depression Inventory, was taken into account when altering the diagnostic criteria in the DSM. And so Beck and his colleagues, to their credit, are really seen as experts in this area. The Beck Depression Inventory has excellent reliability. Its Cronbach alpha is 92 for an outpatient sample, a large sample of 500 people, meaning that each test question is asking you about depression and asking you consistently that way, and so that gives you a good sense for whether or not a client, if they answer one question one way, if they'll answer all questions the same way. It has a 1-week test-retest correlation of 0.93. This is also very high and good, and that's with a smaller sample, which is hard to get with a smaller sample. For outpatients who had been referred for depression and took the Beck Depression Inventory 2nd edition during their first and second therapy sessions. In a study with white and Mexican American subjects, it also had an internal consistency coefficient of 0.80, which was computed for the BDI, and there's an international edition of it. There were no significant differences found between participants. In other words, when it's used with Mexican Americans, it also seems to have fairly good reliability and validity. It's a criterion referenced assessment, as we mentioned before, and there was a diagnostic efficiency study of using college-age students who were clinical, meaning they were experiencing clinical levels of depression. Of those 127 students, there was 93% true positive rate and 18% false positive rate. What we mean by that is that the test correctly identified people with depression 93% of the time. So if you truly did have depression and you took the Beck Depression Inventory, the Beck Depression Inventory saw that, found that 93% of the time through your own responding. However, there was also an 18% false positive rate, which is people who did not have depression, who were not diagnosable, took the Beck Depression Inventory, and 18% of the time those people were diagnosed or could be diagnosed with depression according to the BDI, but not according to the DSM. Now, why is that important? Well, the Beck Depression Inventory doesn't completely follow the DSM, though it aligns quite closely with it, and we always want to be aware of false positives when we're using a test like this. Its concurrent validity with the Hamilton Depression Rating Scale was decent. 0.71 is pretty good, actually, for concurrent validity. So that's when you administer two similar assessments together and see how well they align. The guidelines for Beck Depression Inventory interpretation are a little different than the Beck Anxiety Inventory, a bit different than the Beck Depression Inventory. Here are the guidelines for the BAI interpretation. A score of 0 to 7 is minimal anxiety, 8 to 15 is mild anxiety, 16 to 25 is moderate, and 26 through 63 is severe anxiety. The reliability of the Beck Anxiety Inventory is also strong. There was a 0.92 Cronbach's alpha, which is very high for outpatients, a large sample over 1,000 people, and 0.90 for a college sample over 350 people, also large. It also has a 1-week retest reliability of 0.75. Now that's less than the Beck Depression Inventory, but it's still pretty solid. In terms of validity, it's a criterion referenced assessment again, and it was able to differentiate between depression and anxiety in an outpatient sample. This is important because depression and anxiety share some similar characteristics, as you'll find out about when you take your diagnosis class. So being able to differentiate depression from anxiety is important, and the BAI was able to do this. It has concurrent validity with the Hamilton Anxiety Rating Scale of 0.51, that's decent, and discriminate validity with the Hamilton Depression Rating Scale, which was also solid. We want this to be lower, and it was 0.25. Remember, we want anxiety and depression to be somewhat differentiated. Interestingly, though, it actually had shaky discriminate validity with the Beck Depression Inventory, a 0.48. That's higher than we would want. So when you're using both together, just know that there are maybe times when the Beck Anxiety Inventory may not be truly detecting anxiety, it's just detecting depression rather than anxiety. That could happen, it's possible, based on this high discriminant validity score. Here are some other symptom checklists that exist out there. We've reviewed the Beck inventories. There's also the children's depression inventory that exists if you're measuring depression in children. I've mentioned the Hamilton inventories before. There's also the geriatric depression scale for older people with depression. There's a Center for Epidemiological Studies depression scale that's sometimes used. There's the personal history questionnaire, which is often used, believe it or not, in primary care clinics. For anxiety, there's the Hamilton scale again. There's also the State Trait Anxiety Inventory. This one's an interesting one because it taps into what we call state anxiety, and that's anxiety that happens just during one specific point in time. So let's say you feel anxious when you are high above the ground, you're afraid of heights. Or let's say you feel anxiety when you're in a crowd or when you're presenting in front of people. Those are states. Whereas trait anxiety is anxiety that is persistent across contexts. So for example, if you're just naturally a worrier, that would be trait anxiety. Then there's an OCD inventory that's sometimes used, called the Maudsley. There's the Post-Traumatic Stress Disorder Symptom Scale that's used for trauma, and the Trauma Symptom Inventory. All those, both of those are used more for trauma than for anxiety, but you should know about them. For substance use problems, there's a variety of symptom checklists that exist out there. There's the Addiction Severity Index, the Alcohol Use Disorders Identification Test known as the Audit, the CAGE questionnaire. The CAGE, I believe, only has 4 or 5 items, it's fairly brief. Then there's the Michigan Alcohol Screening Test, and its variant for just illicit drugs rather than alcohol, the DAST. There's also the Substance Abuse Subtle Screening Inventory, and it's in its 3rd edition now. I will say that the SASI, as it has been known, is one of the more rigorous assessment tools for substance use because it includes validity scales. So it may be worth, if you're screening for substance use, to use the SASI. There's also an adolescent version of the SASI that exists, and there's also another assessment tool called the Timeline Followback. That essentially is asking someone to report their alcohol, their drug use, looking back within the past couple of weeks or months. And as you might imagine, that has some problems with just self-report and how accurate people can recall. I mean, just think about it. If you're using substances, particularly if you're inebriated, your recall may be slightly impaired. Eating disorders, there are a couple that exist out there that are popularly used. The Eating Attitudes Test and the Eating Disorders Inventory, the 3rd edition of that. The EDI, again, has validity scales. It's one of the more rigorous tests for eating disorders. For ADHD, there are a lot of different assessment tools for this. The most common are the BASC, that's the Behavior Assessment System for Children, which is in its 2nd edition. The Achenbach system. And in addition, there's the Conners rating scales. A lot of these, such as the Conners, have forms not only for the client but also for a parent and for a teacher, so you'll get a sense for whether or not there's consistency in how people in the child's environment see them as having ADHD or not. When measuring things like self-injury and suicidality, there's the Suicidal Ideation Questionnaire, which is available for young children, high school adolescents, and adults. And the SIQ again has validity scales, is quite useful. There's also the Self-Harm Inventory and the Deliberate Self-Harm Inventory. For anger, there's a couple of things to be aware of. The State Trait Anger and Expression Inventory. That one is very useful again for determining whether or not a person's anger is just based on a certain situation, for example, being at work and being yelled at, or whether it's a trait, they are chronically angry. The Defenberg Driving Anger Scale is also useful if you have people who have road rage. So a closing thought on symptom checklists. One of the things I want to encourage you to be looking at, particularly as you move into clinical practice, is using the DSM-5 Level 1 and 2 measures. The Level 1 measure is a global assessment of all kinds of symptomology, and from that, if a client indicates certain issues, you can follow up with a Level 2 measure to determine whether or not they meet criteria for an actual disorder. Now, these are very useful checklists, A, because they're free, whereas a lot of the others that we've described cost money for you to use. Each time, usually you have to pay a fee, or you have to buy, say, a pack of 30, which is not cheap. But the DSM measures are free, and in addition to that, they ask directly about disorders because they're straight from the DSM. They align very well with DSM criteria. So in my own practice, I often use the Level 1 and 2 measures because I don't have to pay anything for them, and because they also directly ask about diagnosis, which really is the reason I'm using symptom checklists in the first place. That concludes this video lecture on symptom checklists. We've talked about the Beck inventories, some other kinds of symptom checklists that exist out there, and we've concluded by talking about the DSM Level 1 and 2 measures.